The Nigerian Association of Resident Doctors wants the Federal Ministry of Health to expedite action on the one-for-one policy on the replacement of doctors and clinical staff who have migrated to reduce the manpower shortage as a result of brain drain in the country. President of the association, Dr. Emeka Innocent Orji, says, given the high rate at which doctors are exiting the country, Nigeria may end up without doctors, lamenting the poor response of most state governments in domesticating the Medical Residency Training Act of 2017, 6 years after it was signed into law. Dr. Orji called on government to look into the remuneration and welfare of doctors and other medical personnel. The association urged the federal government to prevail on state governors to pay up backlog of salary arrears owed doctors, stating that this will boost the morale of doctors and other medical staff. Well, joining us is a public health consultant, Dr. Tuyi Mebawondu. Good morning. Thank you for joining us on TVC Breakfast.
Good morning. Good to see you.
I hope you have new Nard notes.
We have to ask the banks.
Now, Dr. Tuyi, let's begin with the number of doctors we have currently, because that is really the crux of this matter. We have seen the mass exodus of doctors out of the country, medical personnel, basically. What's the number as it stands right now?
Before I create the global thing, let me explain that of Nigeria. From 1963 to now, we've produced 93,000 doctors. 93,000 doctors. So that amounts to about 1,500 every year. And we have 24,000 registered left. Out of 93,000 we produce, we have 24,000 doctors now. Out of that, we have maybe about close to 17,000 who are resident doctors. So, you know, when Dr. Orji was talking about not having doctors, it's going to happen sooner than you can imagine. Our capacity to produce doctors is just like, 3,000 at best if there's no strike per annum. And then we're looking, now Nigeria is, is a signatory to universal health coverage. And universal health coverage means that you must have human resources to deliver your health outcomes or whatever you want in your health. And that is 2030. That's the magic here. That 2030, if we have to produce 12,000 doctors yearly, okay, that means that we'll have about maybe 70% of what we're looking for. But we can't get that. And it's obvious. Now, why do this surge of doctors, why is it so pervaded and interesting? Globally, I'm just using doctors as a point, health workforce. Globally, there is shortage of health workforce.
How come?
In fact, the estimate is that by 2030, we're going to have between 15 and 18 million shortages of health workforce.
Why?
Worldwide. Why? We are not producing enough. Health is changing. Diseases are mopping. COVID came. Even Nigeria, we have all sorts of chronic diseases are there, and you need doctors to intervene in that regard, and even health workers. Now, if you compare two regions that have similar population, let me look at the Americas and Sub-Saharan Africa now. Similar population. Okay, now the health workforce, in the global health workforce, Africa accounts for about 3% of global health workforce. America is taking a chunk of as much as 40%. Look at that. Spending, global spending. 50% of global spending on health is put in Americas, whereas Africa has less than 1%. The burden of diseases, okay, America has 10%, we're having 30%. So you can see the challenges we're having, how complex those challenges are. And now, Nigeria, you come back, you are seeing this kind of health workforces. Doctors are not being trained sufficiently, okay? They are not staying because they have to egress. Tell me, Mike, how do you expect, for instance, that you are a doctor or anybody at all, you have to face this, what we call monetary healthscape. It's healthscape. You can't define, how do you define it? Whereby, you have to wake up, no money in your pocket, you don't have fear, canopy of darkness all over you. Why we want to stay in that environment? So, the challenge goes beyond health system. So, solving Nigeria's human resources for health, it does not reside in health system alone. Because if you look at the narration, you have the finance aspect of it, you have the education aspect of it, you have the labor aspect of it, and you have the health aspect of it. So in reality, it has to be a more inter-ministerial approach to look at those things. Here you have 30,000. Okay, in the Nigerian Health Registry, Facility Registry, says that we have about 41,000 health facilities, clinic, primary health care centers, and all those things. 41,000. You know, these 41,000, 30,000, about 31,000 are primary health care centers all over the country. Only 6,000 of them are functioning. Okay? And they're under which government? They said local government. Abi? Yeah. But in reality, local government cannot run those things. So if we want to solve the problem, we have to start thinking from that position. And then the Residency Training Act says that the only request they made from government is this: pay for our update training. You pay for our update training, at least, you know, there's primary part 1, part 2. Pay 2 update training, part 1. Pay 2 update training, part 2. How could that be difficult for any government to do? You just throw them. And then the other myth I need to bust is this. Even the MDC, Medical and Data Council, says that, you know what? We are subsidizing training of medical doctors. How come? What you provide for training doctors are just the teachers, Abi, and the classroom. Every other thing, books, feeding, accommodation, resides with the person or the parents who have to actually bring money out to ensure that those things are provided. And they are quite heavy. You are not just doing that for doctors. Lawyers are being subsidized, accountants are being subsidized, journalists are being subsidized. Everybody is being subsidized, provided you pay this kind of school fees in Nigeria. All of us are being subsidized. Why will you now? Even politicians are more subsidized. They take all the money, and you're now saying that people that are saving life, that is so important, you know, you would not train them. You are now claiming you are subsidizing them, that they are getting medical treatment cheap, then medical training cheap. It's not so. It's not so. In reality, you know, it should be such incentives to drive, you know, human resources for health. Because without human resources for health, look at Nigeria now. Lassa fever is back. Diphtheria is running. COVID is still hanging there. We have all sorts of diseases. How are you going to do that if you don't have requisite medical people to attend to your patients? How are you going to do that?
It's quite the scenario when I was doing reading up on these issues is quite scary. Yeah. Now, from the data you gave, if we have since 1963, if we have trained just about 93,000 doctors, that is still inadequate because from the reports, I think Premium Times report last year said we need about 363,000 doctors.
That's the magic number.
Exactly. The magic number, 363,000 doctors in Nigeria. That is what the ideals are supposed to be. But if we are faced with the reality of doctors looking for greener pastures, as it is, we recall sometime in the 90s under late Professor Luke Ransom Kuti, where it was said that was the peak of the time Nigerian health had the best of its time. And the magic that time was the issue of primary health care, which was the focus. At the level of primary health care, of course, is more of prevention and then early detection, checking and so on. Is that the way to go now for us to, if doctors at that level are leaving, and then we can say, okay, let us work with at that level so that everybody feels the impact at the grassroots level? Because at that time, it was still local governments that were involved in primary health care. Is that the way to go?
Unfortunately, those local governments, they are not having autonomy.
Yeah.
Surprisingly, a state that I look up to so much voted against autonomy of local government.
Right.
You know, now, of course, like Riley pointed out, primary health care have been the rational place to start. But you see, they are not sustainable. Human resources is challenged. Funding is a problem. So it becomes clearer to us now that even the local government cannot run primary health care effectively. So now, we now have to really think, if this is our basis, how do we now manage these things? Now, can we have adoption of primary health care centers? Can we have community buy into the primary health care center? how do we reroute the sustainability of that primary health care center? So our deep thinking now should be at that level. Because, listen, I can tell you in Lagos, I've gone around every tiny villages around Lagos. Name it, you understand? I can tell you just how many minutes boat ride from Victoria Island, just about 10, 20 minutes boat ride from Victoria Island. You will see primary health care that grasses are growing there. Nobody comes there, okay? Now, so we are going to repeat the system unless that level of community ownership and buy-in, adoption of primary health care center comes in. You have to redefine the model of funding and the model of staffing of the primary health care centers, or else the problem will continue. You have to push critical education in health literacy. People, here we are, this is how we are, and so on and so on. You have to engage not-for-profit organizations and NGOs in actually trying to, or faith-based organizations, in trying to drive some of those primary health care. But there is no trust in government. Yeah. People don't trust.
That's where I was going to go to.
Because what will happen is that there are always policies somersault. Somebody will come today and feel like this, and then look at, in my projections, I had thought that I'm in an election month that I'm going to enjoy at least for the next 2 months. Look at the healthscape I'm facing. Look at the healthscape. How do we explain this? That few days to an election in Nigeria, when normally they give palliative, normally they do cash transfer, normally everything seems to work until after the election. But that is the point where we're having the worst, the grinding individualistic culture happening, and then you want to, what else can work then? And then let me tell you, you know why health is like this? Government don't care.
Really?
Government doesn't give a damn. They don't give a hoot about health system.
Why do you think so?
Because they can easily jump into their listen and go and access health elsewhere. They don't care. If government cares, honestly, and that's the story point, if you don't have the political buy-in, or support for your health system, how many times have we been speaking here that, declare emergency on human resources for health? I had made suggestion on creating health observatory, human resources for health observatory. The human resources for health observatory is a thing that, in real time, look at training capacity, look at what we are producing, look at gaps, and then start to figure out to fill it. But again, universities are supposed to train, that's education, right? Secondary school, they're supposed to teach science, that's still education. Yeah. Motivation for the youth, that's still education. University, education, okay? Strike, unending. When you want, you are supposed to spend 6 years for the first degree in medicine, you spend 10 years. You require special begging for people to want to embrace that kind of profession, okay? And then when they finish, to get a job is another wahala, as if they are having too many doctors. That becomes residency. To enter into residency is a problem because the capacity to train is constrained. We're not really figuring out how that can flow, okay? Now, it's not about amount of money you have. Cuba is having one of the best set of doctors, sending doctors to Italy, big Italy, America learning from Cuba, you understand? It's just that commitment of Fidel Castro government to say that, listen, we need to change this narration, we must be known for this. If there's no government commitment, if there's no political will to do anything, we will stay here and talk about human resources for health, but we are getting to point zero. Because when I was 1988, when I got registered permanently as a doctor, my number was 16,767. Permanent number, 16,000 doctor. 16,767 doctor in Nigeria. Yeah, so if I was 16,000, how many years ago? 30-something years ago, and we're still at 24,000 doctor right in Nigeria. So what does that tell you? We are going to a grind. We get there.
We are getting to a grind, like you have pointed out. But then, if we get to that point, paint us a picture of what it will be. Perhaps that will help us wake up everybody's mindset to know that we need to address this as quickly as possible.
You know what? The first casualty will be economy. People don't seem to be able to connect economy and health.
Right.
Because you see, if I have to do a country report, the health system comes first. Population, birth rate, the health system, so that am I going to have healthy workforce? that's going to work for me in this country? So your economy, nobody will invest nada. Don't go and shout, you are wasting your time. We must be able to connect that. Secondly, social unrest will increase. Now, look at the way, the government is igniting social unrest. People are blocking road. Hunger will increase, violence will increase, mental issue will increase. And then what does that do to your workforce and your economy, ability to build up your country? Now, all these things, you know why we're shouting? Because all these will end up in our consulting rooms. Doctors will bear they are the first casualty when there's a humanitarian crisis, because you see injuries, you see mental challenges, you see hypertension, they will run to you. And you just have 24,000 people who's going to attend to all these things. How do you want them to do it? So in reality, health care is the first point of prosperity, is the first point of economic growth. And people should get that clear. Go and put all the money in a sick society, you are wasting the money. Go and put all investment in a country that cannot even deliver vaccine. We saw what COVID did to everybody. We saw what health challenges did to few presidents in this country. The country nearly ran aground because some presidents were sick. So, and then now, you are looking at me, and then for a president of a country, it's a very, very interesting thing that you must not allow your enemy to know exactly the depth of your health system. We cannot produce drugs. The active pharmaceutical ingredient cannot be produced anywhere. You have to import all those things from India. We cannot produce vaccine. We have to depend on Bill Gates. Who runs a country like this? So if you don't have health, you cannot. If you want to do mass suicide, if you want apocalypse now, let us just enjoy the apocalypse. If 4 of us remain, no problem. So that is the clear picture of what we're saying. That if you neglect your health system, of course you read Bible. When they were asking Israelites to leave Egypt, Pharaoh didn't answer until health problem came. Job was such a honorable man until he fell sick. What are we talking about? So there are clear. In fact, the summary of the coming of Jesus, whom they call a physician, was that you may have health and have it more abundantly. I'll be waiting to remain now. He didn't say you have money. So I don't just understand why people cannot situate how important health is. And I wonder, because again, in reality, sometimes you really want to do a psychiatric examination. What exactly is going on in the mind of all these people, that are controlling our affair? Okay, 4% of our healthcare. What would that do? It won't take care of your cosmetics now.
It's a serious
Dr. Mebawondu. I know that feeling. I think the point there is we also have to make you a pastor this morning, maybe, so that it adds up to your CV. But the point there is, as it is right now, the picture you're painting is really scary, I must say. But let me take it from this other side. A lot of Nigerians, I've heard some people say that, well, if doctors leave, we might have to fall back to our native traditional practicing that we used to do before. Before the orthodox medicine came, Nigerians used to, or Africans used to patronize that. Will that bolster that part of things?
Can it bridge the gap?
Maybe bridge the gap. As much as everyone says that, well, because you can't measure scientifically, but then people see results here and there.
Obviously, when you are sick, you seek for treatment elsewhere, anywhere. You go to doctor, you go to pastors, you go to shamans, you go to priests, you go to witch that. You go everywhere. Because that's what sickness imposes on your mind. You understand? It makes you cannot take rational decision. So now, well, if we revert to that, we'll also revert to, since we're not having EPA, we have reverted to lantern, abi, and candle. It's okay. We'll keep reverting. And then we now want to say, we want to be the social economy, this social number of years. What kind of lie is that? Revert to whatever you want to revert to. But, unless we start importing chatbots, AIs that can do treatment, the world is moving forward. The world is moving forward. What kind of savagery?
Regression.
Because now what will have to happen is that they'll say, okay, concussion, For hypertension, go and bring the bone of goat. Go and bring the teeth of lion. Go and bring they cook, concord everything, and then you start drinking it. Okay? So if you cannot rationally put it, and then you plug this, I plug that herb. It used to be those days, and growing up in the village, they would just put a pot, put up pots inside and cover me with it. I'll be, when I have malaria. Yeah. I'm a village boy. So but again, I look back and I figure, must I go through that kind of thing? But even the native care, our own native medicine, a lot of charlatans, a lot of quacks, people that are not having proper training. Even if you had done that and said, listen, you know what, which of them really work? And try to look at it and streamline and regulate properly. Perhaps that will help a bit, But a lot of charlatans, when you are in the bus or the bus stop, Agbo Jedi. And I wonder what is Jedi? So every small boy is ringing bell to come and buy something. That will be challenge, And most of the time, the next thing is that you see a lot of miracle workers. And I keep saying, the more miracle workers I see, the more people ringing and selling this thing inside the bus, the more indictment for health system, the more indictment for government. Because in reality, if you have access to top-notch health care, you will not go to a miracle worker now. You will not go and look for Agbo Jedi now. So it's an indictment that we have searched, we cannot assess. And then one of the key things for assessment is that, because, 80-90% of people is out of pocket health expenses.
Yes.
Okay, now, let people go and fall sick now when somebody chooses to ignite social unrest with currency and fuel supply. Let them go and fall sick now. How do you now move people around? So we're looking for a state. This is my own way to look at it. We're looking for a state that can honestly sit down and say, I'm going to really fix the health system. It's not so difficult for everybody here to have a link to either a primary health care center and a health worker, which we can actually do that so that you have a way to take real decision when you are not feeling well. But as it is, we're going to a grind, and we're going so fast.
All right, we are counting down to the election. A change of government will be happening soon. So what should whoever comes in look at in terms of budget, everything that affects healthcare? How should it be addressed?
The person must actually understand that the importance, the pivotal importance of good healthcare to the citizen. When he understands that, he will look at it as, listen, I'm declaring a sort of emergency in the health system. And the emergency will involve, training, retainability and limiting attrition, okay? And of course, pushing a lot of visuals, a lot of campaign, a lot of literacy work on health and how to assess health. Now, why can't you incentivize those people, studying health? Because at the end of the day, even if they're going to pay the money back, let them feel good. Let them take that pressure off their head that, wait a minute, I'm studying this thing, government is making this provision for me, my books, my equipment, my everything is there for me. Yes, I've been given 500,000 naira to spend for this year for my health. Let me now focus on my book. You can then use that to say that, listen, you have done this, so what we're going to do is that you have to be with us for this number of years before you leave. And then let me tell you the categories of those people living. If there's a fresh graduate will not come back. Now, somebody trying to get into residency and couldn't get it and happen to leave will not come back. Young consultants that live to the country will not come back. But the experienced consultant might say, okay, listen, I've suffered enough, let me go. Those by the time they're coming back, they don't even want to work for you again. They don't want to work for you again. So you must really discuss, intercourse, health, human resources for health, create health, human resources for health observatory in each of those states, and use it to drive your policy.
All right. We have to leave the conversation here. Dr. Tuyi Mebawondu, thank you so much for your time on the program.
Thank you for having me.
Thank you.
All right.
Right.